And I'm really happy to meet all of you. So in the history of newborn health, Nepal has really been a leader. And here we are to talk about how you're also leading, joining up newborn health with child development. So what I want to talk to you about is how we can change things for the future of children here in Nepal, but also beyond. And I love the introduction that has just come, because the rights of the child are intertwined. But to make those happen, it isn't just that we have different sectors, but those sectors usually aren't intertwined, even within our own organizations. And to make this work, we need unlike minds to think differently. So maybe you're here as a nutrition person and you don't normally think about the baby, or maybe you're here as an education person, or you're here as a sector person. And I challenge all of us to get out of our normal mindset and to be ready to meet with unlike minds. So what I want to talk about is the future agenda. Survive is still a future agenda, it's not completed. Thrive, what are we going to do differently to really ensure that children and their families have that opportunity? And then transform. And transform isn't just about social and cultural change. We have to transform our systems, because systems are going to have more and more threats, whether that's climate change and floods or uncertainty or terrorism. Systems will also need to be transformed, and we need to be looking forward to that. But before we look forward, maybe we have to look back. Because if we don't go back to learn, the first countries to really have a major strategy for reducing maternal mortality. And yet at the end of that era, we halved maternal deaths, but still more than 300,000 women dying, mostly needlessly. Child survival. We more than half deaths after the first month of life, and yet still 3.2 million dying around the world, and particularly driven by stunting. And that particularly actually links to in utero stunting. A lot of our failure to address stunting is because we haven't gone back up the life course. And then in the middle, 2.7 million newborns dying. And why are we now paying attention to newborns dying? Well, it's not because mothers in Nepal or Malawi whose newborns die get out on the streets and shout about it. It's not even because we have funerals for these that society recognizes them. It's almost entirely because of the Millennium Development Goal for child survival, and the fact that worldwide now almost half of under 5 deaths are in the first month of life. Here in Nepal, it's almost 2/3 of your child deaths are in the first month of life. So this is driven not by political leadership, but actually by accountability around a target. And then in the middle, 2.6 million stillbirths, so babies dying in the last 3 months of pregnancy. Most horrifically, 1.3 million that die after the woman goes the whole way through her pregnancy. She goes into labor with a live baby, and that baby dies. That should be one of the most unacceptable things on the planet, and yet you hardly hear anybody talk about it. And why is that? It's not just that we didn't have a target, but actually everything that we measure in the UN system starts from live births. Even C-section we measure per 100 live births, which makes no sense. So these babies don't count, and the people who experience the deaths don't have a voice that counts either. And despite fantastic progress for Survive, we still have 9 million deaths of women and children around the world, and it's bunched towards the time of birth. So the maternal deaths are around this time period, and also these deaths of stillbirths and neonatal deaths. So in going forward, we need to look differently at this time period. And this time period is not just the greatest risk for your survival, it's also the greatest risk for brain injury. And it's all about timing. It's all about seconds and minutes counting, either for the mother and particularly for the baby. And that also applies for your brain growth and development around this time. Being born even 2 weeks early means you have less brain growth. Being asphyxiated even for a couple of minutes can knock off 20 or 30 points on IQ. Much bigger effect than even being undernourished for a longer time period. So this is a time of greatest risk, but also of great opportunity for change. And yet, there are still some invisible places in our thinking about this. So if we've looked back, we had 8 targets. Probably most people in the room could have told you what most of those targets are. Who can tell me what the new target is for child? So the 3.2 room of experts. What's the target? Which year and what's the amount we're trying to reach? Anybody know? Or you're all just being very polite? Well, I tested Richard Horton at the Lancet, and he couldn't name any of the health targets. So I reckon if Richard Horton doesn't know, we're in deep trouble now. We went from having 8 targets that were quite simple, that were proportionate reduction. Now we have absolute targets that most people can't remember, and they also differ by different countries. And we have multiple indicators. So it's a different world. We also have a different dialogue. So the dialogue during the Millennium Development Goal era was, you had 8 goals, 3 were health. And that was because people believed that health led to development. Now we have 17. 1 is health, and it's the other way around. Development, we hope, will lead to health. And of course, it's a two-way street. We need both. You know, health and development should walk together. But we've had a total flip of the coin. So it's a very different dialogue around us. So if we look at this, we have, you know, much more complex targets within this time period. So making the case for health, for development, and the links with education and with nutrition and with poverty alleviation, we will have to be much more joined up. So I really salute, you know, UNICEF as an organization in how you're trying to do that in a smarter and better way, and also you here for bringing together these minds to think about this. And if we look at the UN Secretary General's global strategy for women, children, and happy to say adolescents as well, it's based on this future casting principle of survive, thrive, and transform. And that's how I would like to structure the talk that I'm going to give to you now. What more do we need to do for survival? And particularly I will look at the newborn. And I think here in Nepal that is 2/3 of your deaths pretty much. So you absolutely are doing more than many other people are doing, but you also need to be preparing for what next. And then thrive, and then transform. So if we look at this, I want to flag the maternal target going forward. So the target going forward now is a global average MMR, which means that because it's a global average, countries have to set their own target. And I believe that you in Nepal have set a target for reducing maternal mortality ratio. And this intimately links to what we do for family planning and sexual and reproductive health. So if we move forward from target 3.1, this is 3.2. So the target for the child is that by 2030, every country will have an under 5 mortality rate of 25 or less. And then for the first time in the history of the universe, we also have a target for the neonate. So that neonatal mortality in every country will be 12 or less. Good, because it sounds simple. Problem is that 100 countries are already below that. So those 100 countries still have to set targets, particularly around reducing inequalities. But the corollary of that is that 30 countries, particularly in Africa, have to more than double their rate of change. So they have the steepest climb ahead of them. And then UNICEF, and particularly under the leadership of Nabila here in the New York office, are helping 51 countries that have volunteered themselves to track what they're doing around their Every Newborn Action Plans. And of those 51 countries, 43 have set specific targets, including Nepal. And then if we look at stillbirths, so there's a stillbirth target that was set in the Every Newborn Action Plan and through analysis in a Lancet series, and that is also to reach 12 or fewer by 2030. And in this case, 60 countries have to at least double their rate of progress. So it's a steeper climb, but there are things that we can and must do, particularly around the intrapartum stillbirths, which should be unacceptable. They don't happen in countries with obstetric care, and they're 20-fold higher in countries where we're not providing quality of obstetric care. So what about Nepal? So congratulations, you had the delivery of the Nepal Newborn Action Plan, and I know that the government did a fantastic job in leading that, and UNICEF and many of the colleagues here were critical for that. So you had seen almost 3/4 reduction of under 5 mortality, successfully more than meeting the Millennium Development Goal 4, but the neonatal mortality reduction had been slower than that. So you have set this target to reach a neonatal mortality rate of 11 by 2035. And also congratulations, you're one of the few countries that has set a stillbirth reduction target, which is very important. And my last time that I came to Nepal, I was here with Ashish, was a few years ago, when I was here to learn from Nepal. We were doing a BBC documentary comparing two countries that had almost the same level of neonatal mortality rate, both better than all their neighbours. And we were comparing Malawi in Africa and Nepal here in South Asia. And you had taken completely different paths. In Malawi, it had been mainly through facility-based care linked to maternal health. And here in Nepal, it's through the great success of your primary healthcare program and particularly the FCHVs, and I learned a lot from that. But one of the key things that I think both those countries did was to look at your health management information systems. Because whether you're working at primary level or at hospital level, if you aren't measuring things, you're unable to change them. So this week we are here. I think in the introductory remarks you said 10 countries, so Nabila will tell you that every day it seems to be more than. How many countries is it now? It's at least, is it 12 countries coming for your meeting this week? Yeah. And the total number of participants is 80. Now up to 80. And what that shows you is people know that we need to do better for measurement. So often, if we look at maternal and newborn health, we just moan about our metrics. If we look at immunisation, the metrics are amazing. Not only can you say who got immunisations, but who got how many, who got left behind, which districts. And if we're going to change maternal, newborn deaths and stillbirths, we absolutely need to do better. Not just at project measurement, but at systems measurement routinely. So that's what this meeting is about. And in the Every Newborn Action Plan, we had some specific targets around vital registration, around perinatal audit and scale up and use of that data, and around core indicators being defined. And here in Nepal, you're one of 3 countries in the world that is leading a very large-scale research in this area. So in this study, the EN birth study, which is observing 20,000 births, Nepal is one of the key leaders here. And then we're hoping to link this study of observing births into a child development study and follow those children up and also help to simplify some of the child development metrics. So I think that it's really critical that we think about how we will get there. So this EN birth study, which Ashish is a key leader for here in Nepal, we're looking at what happens in labour wards, looking at what's written in registers, and looking at what goes into the DHIS too, and then saying, how can we pick just a few things that actually happen, that are recorded, and that can be used to change practice? So trying to use rigorous science to validate, not just say here's 20 more indicators to dump on your HMIS, but here are some selected things that we really know are useful. And to keep the end in mind, to think how those will influence and change programs. And then very pertinent to what we're discussing today is we then recognize that for child development, we have really quite complicated metrics. There are multiple ECD tools, and it looks like I've got a typo there, so I must also need some help with my development, which are very complex. So how can we look at embedding, for example, simpler tests with an immunization visit? How could we do that to join up what's happening at birth so that every child can also have child development outcomes? But if we look to where Nepal has learnt, particularly at community level, and what can be done at the community level, this was a series of papers that we launched last week in London, and Ted Bab, who's here from Ethiopia, was part of the work in Ethiopia. So this was 7 countries and 10 years of work to say, what are the aspects of what work for survival, for maternal and newborn health at community level? So just on one slide, and I think this will really resonate with a lot of the stuff you've done here with the FCHVs, let me just show you some of the points here. So community programs still require a health system approach. We still need metrics, we still need to think about human resources, we still need to think about commodities within those. Particularly if we're having multi-purpose workers, as you have here, what we can give them to do for the newborn has to tie in with everything else that they're doing. You can't give them lots of complicated things that are a very high time load if they already have lots of other tasks to do. And then if we bring complex content such as community treatment of infections, which we do have to do to reach the poorest, but if we do that everywhere, then it also means we will have a trade-off on how large scale we can get to achieve that. And then very importantly, particularly as we push down neonatal mortality rate and more of the babies who are dying are the preterm babies, what we can do at home is not going to get us the impact that we need. So we have to have this critical shift, not to have community and facility competing, but how do we link and make that work, especially in a quick way. So how could we learn in thinking on the future agenda for survival? How can we learn from what actually was very slow change? So in Nepal, you have gone much faster for reducing neonatal deaths than this data from the UK and the US. So the UK and the US in the year 1900 was about where you were maybe 20 years ago. And you have gone, if we look to see where Nepal is now, Nepal is between here and here, so just around 18 or 20. So you have made this change within 20 years instead of 70 years. It's very impressive. But if you want to keep up that pace of still going faster, then you need to do different things. So if we look at this first phase, the first phase was public health approaches, tetanus elimination, water and sanitation, behavioural change at home, breastfeeding. The second is obstetric and neonatal care, and this is where you are now. 55% of births are in hospitals. C-section has gone up a lot, maybe too much, or maybe not quite the right people always. And then resuscitation, which really you have been leaders in the implementation for this. But to get to your target, you're going to have to bite the bullet of also neonatal intensive care. And how are you going to do that in a systems way that is going to work and be sustainable in terms of human resources, in terms of equipment that can be actually maintained and be cost effective? Is really a critical question. So, the good news is that recent innovations can actually make that faster. So, the shift into facilities now is both good news but also potentially bad news. Because if we look at what's happening in some of these facilities, so this is a hospital that I worked in for 4 years in Ghana. This is just over the border from you in India. We're bringing people into facilities, but actually for the women and certainly for the babies, in some cases we are doing more harm than good. You know, there isn't space to properly have skin to skin to breastfeed. We're probably introducing not just infections but multi-drug resistant infections that we aren't monitoring. So we really need to think about what we're doing here. That's the bad side. The good side is people are here, and if we pick the right things to do, and particularly with quality improvement, we can change. So if we look at the evidence base that we have a massive evidence base around hand washing and hygienic practices, but we're pretty terrible at doing it. We have massive evidence base around breastfeeding, and in Nepal you have been better than many other of your neighbouring countries, but we still don't practice or get the level or sustain what we need to do. So if we look at this, we have a mismatch of action compared to evidence base, even for simple things, for these facility births. And then if we come to slightly more complex things like resuscitation, it's more difficult. It's not just giving the training, giving the equipment or whatever. And I would really like to flag Ashish, who's sitting here in the front row, and his team that I've been listening to this morning. I learned a lot from them. Not least of all the fact that when they publish a paper, they have to buy the team a cake. I thought that was really an excellent idea.
Good tradition.
So these are just some of the papers that Ashish has been publishing, and this, you know, is unique. It's not happening in lots of other countries. And I think that having this within UNICEF, you know, having implementation research, not just talking about it, but really driving how we use data in a rigorous way to change programs is excellent. And this is something that is now moving forward into larger scale up in 12 hospitals, which is fantastic to see. So in terms of the other things we talk about for newborn survival, one of the things that has got a lot of attention is kangaroo mother care, tying babies to the mother or to the father or grandmother's front, and not just for warmth but reducing infections, helping with breastfeeding. And these days when I come to show kangaroo mother care, I always pick a picture from Sweden or from England. And that is because actually the places in the world that are scaling up kangaroo mother care the fastest are the high-income countries. And what are they doing it for? It's for child development outcomes. So if you look at these preterm babies, you know, they have lost brain growth even by a few weeks, being born too early. Some of them are being born 3 months too early. So this is a critical intervention for child development as well as for survival. And yet we're probably slow, and I think particularly slow in many South Asian countries, and I'm looking forward to learning from people this week more about why that is. And I think we shouldn't be thinking of KMC as something we do only when we don't have machines for poor people, because it's actually part of family-centred care also for development. And with that, we still have to bite the bullet, and I know that here in Nepal you're starting to, well, you already have some fantastic newborn care units, but you're really looking at how to scale that up in more district hospitals to get equipment and to move forward. And I think we have a lot of challenges with the equipment, because the equipment is usually designed not for our settings. So one of the exciting opportunities, if you look at this baby, so I don't know how many of you have seen a preterm baby. This is a preterm baby from Malawi called Chikonjetso. This is him at the age of 1 day. And you can see he's really struggling to breathe. So in this situation, you know, to move forward, we definitely need to look at the equipment that we need. And Malawi has been leading the way in developing more robust, simple devices. So for example, a CPAP device, so to help babies breathe, that has been designed in Malawi and is being marketed now in 40 countries. And it's about 1/10 of the cost of the normal CPAP device. And it's built so that if you put a great big power surge through it, it doesn't blow. And the one part that's likely to blow, it has 3 spare ones underneath the back, underneath a kind of screw-in plate, so really designed to survive. And at the moment, the MacArthur Foundation had a challenge grant for 100 million, and out of 1,900 applications, there's a group from Rice University, and that I'm also associated with, that's one of the last 4, and it's the only health one. And if we're to get this grant, we would be able to start to manufacture these packages of newborn care devices, because one device alone is not enough. You also need the pulse oximeter and the IV fluid dispenser and so on, for about $11,000 for a district hospital that does 4,000 births a year, so very sustainable cost. So we're hoping that it will be possible to win this grant, and if we do that, I think it can be transformative for newborn care. Because you need all these different pathways and a number of different devices, not just one alone. So I want to finish this section on survive by saying we have to get beyond our goal just being surviving to 28 days. If you're the mother or the father or the family member, that's not enough. What you want is for that child to survive to 2, to 5, and to grow up. So this is Chikonjetso, the baby who you saw struggling to breathe, and his name means conqueror in Chichewa. And this is him aged 2. So how are we going to link those newborn health programs and the survival agenda into what we do for Thrive? So I think to thrive, you need 3 different things. First of all, you need to not have your brain damaged. You need to prevent against damage. Secondly, you need to be able to grow the right nutrition and not having infections that can be prevented against. And then thirdly, you need the right environment that will stimulate you. The problem is that we tend to separate those into sectors. You know, we have health doing one thing, stopping brain injury. We have nutrition thinking about the growth. And then we have the education people thinking about the stimulation. And we can't segment them, because if your brain has already been badly injured, stimulating you isn't going to be the only answer here. So we really need to think about how we do that together. And particularly the things that cause babies to die also damage brains. Whether that's birth asphyxia, whether that's being born too soon, whether that's jaundice. So we did this work a number of years ago, but I would really like to underline that if you look at disability-adjusted life years worldwide, more than 8% of them are directly linked to neonatal conditions. So if you want to make the case, not just for survival programs, but for child development programs, this is a key piece of information for you. And another point here is that the disability that we're seeing in middle-income countries, so in low-income countries, it's still about the deaths. Unfortunately, we still have babies dying of nothing. But in middle-income countries, as we start to scale up intensive care, if we're not careful, we have preventable disability. It's really a marker of quality. And if we don't think about that as you scale up your intensive care, if we don't measure it, and if we don't reduce it, we're going to be in trouble. And for example, blindness after prematurity, which is Stevie Wonder from the US, he was blind from early neonatal care in the US a long time ago. But we're recreating that if we don't think about it now. So, India, for example, as well as building their special care baby units, they're also scaling up screening for retinopathy of prematurity. So we have an ethical responsibility that if we scale up more comprehensive newborn care, we also have to scale up how we will look after and identify these children and prevent problems with them. Because disability is even more sensitive to quality of care than death is. And there are key research gaps here that we need to think about and follow up on. So how do we move forward into the child development agenda? Not just avoiding having your brain injured, but stimulating and maximizing your outcomes. Well, I think a critical thing is to look at the most vulnerable, to look at the life cycle, and to see how we link this up. The burning question is, how do we do that? So who's heard of Saving Brains, the Saving Brains portfolio? It's an interesting name. So it's Canadian Grand Challenges have put several $100 million into innovations for child development. And we were recently part of looking at this portfolio and saying, what can we learn for large-scale implementation for child development?
So all those packages, if we, and Joy had already alluded to them, is talking about the first 1,000 days, starting from the pregnancy itself. Then early learning and protection. And then also, like at the different phases of child's age, there are different requirements, and these need to be filled. But while we are thinking about the child, there is also a caregiver. And there are also parents, there's a mother, there's a father, there's maybe grandparents. So we also need to care for those caregivers. And we also have to nurture the family support and strengthening mechanisms. So when we are talking about, and later we would come up to, which children are really more vulnerable. It's also like, the mothers who are suffering from depression themselves, can't care for their babies the way they should be caring. And now there are also studies coming up that fathers' depression levels also affect children. So it's not only mom, it's also the father. And with this whole movement of nuclear families, so also children are not getting enough support from grandparents that they used to at one point in time. So the three simple, you can say, divisions, for multi-sectoral engagement comes for nutrition and health, protection, and then stimulation. So anything that a package would include would be focusing on those three areas. And then we think about, okay, but we are already doing those things. So what's different in this package? We are already immunizing, we are starting off our newborn care programs, maybe not to the scale that we want to, but at least we have started. And we are already doing child protection programs. We have ECD, also in the early education program. So stimulation was there, but what's different? I think it's also like between sectors, we haven't thought about that at what particular age, what is the child's requirement, and are we giving all those three things together or no? When I was working in East Asia Pacific region, that's the region where there's very high levels of female employment, though still in informal sector. So when moms were going, they were leaving behind children in daycares or having household support. But the level of child care wasn't of quality. Children were falling, getting injured, So how those protection elements would come in. And when we think about stimulation, we talk about like talking to children. Does it come automatically? The grandparents used to tell stories, but now do the modern parents still think that it's important? So again, another way to talk about SDGs and how the child would be at the center of all this. And then the 5 essential elements that we have: health, we have nutrition, we have responsive caregiving, security and safety for the child, and early learning. So all the nurturing care would fall into those domains. So now when we talk about all this, and we talk that most of those health interventions maybe we are already doing, but still we have so many missed opportunities. Okay, I've just put in the numbers for Nepal. We have SPA coverage more than 55%. But we have a gap, Not all those babies are getting breastfeeding within first hour of birth. So while this gap is very low for Nepal and even wider for other countries, but it still exists. Okay, so now I'm switching to some of the examples from countries who have started this kind of package ECD programs. So this first example comes from Serbia, where they had an already visiting nurses program, and they started this nurturing care training for those nurses. So it's also building on to, as Joy was mentioning, the context, where are the entry points, where are the opportunities. So that country had this opportunity, and they trained their nurses to offer parents, this advice and support. And they were also kind of monitoring, mothers, that how they are coping with their new role, and all, especially the first time moms, they needed more support onto that. Then another example from Pakistan, where they did a study of, on lady health workers program, and they trained one in an intervention group, lady health workers, to teach moms about increased psychosocial support and stimulation, but in the control group that wasn't there. And then they found out that at age 1 there was increased cognitive, language, motor, and social emotional development in the intervention group as compared to the peers. And in China, they used the online portal to reach to moms and parents, and giving them messages and to say, okay, what do they need to do for their children's development. And they found out that they have really reduced the children with suspected development delays from 37% to 19%. Just to tell you a story about China's program, the country office was developing their 5-year program, and they were looking at examples of what they can do for ECD. It was very interesting discussions, but all of us didn't have a clue about how are we going to do that. And later, our colleague from China came over to New York to tell the story, how they went about it. So they focused on the vulnerable population, the most deprived children. They did the poverty ranking of the provinces, and they chose 2 of the most poorest provinces in China for this intervention. Then they formed an inter-ministerial committee, and they wanted education to take lead of that. And education sector said they didn't want to have this responsibility because they were engaged in some other programs with much engagement. So in the end, it went to health, but it was really housed into the social welfare department's approach also. And they found out that once they had identified those families and provided care through the volunteers, even simple interventions like providing colorful blocks or balls, those play items really made a difference. So it's not very, you can say, high-tech things or very expensive things, but very simple things that could do the difference. So now coming to where we see in our programs, opportunities to include ECD. One thing that we have started working on is to have an implementation framework to develop it jointly with WHO. Ted Bob was at WHO a month back, and the discussions have started more to talk about what kind of delivery platforms would be used and what would be the engagement strategies. And of course, the first 1,000-day focus that comes in the SUN program and other areas, we need to sustain that. Then we also have to integrate early childcare messaging through community health workers, the ICCM programs, and M-Health initiatives. I think many of you would have heard M-Health 1000-day messages. So in that, the childhood development messages could be included. Then, of course, all the contact points which health sector has the privilege of, the antenatal care, postnatal care visits, EPI contacts, growth monitoring contacts. How can we integrate early childhood development in those contacts? And then simple things that we are doing in newborn care. We are talking about early skin-to-skin contact. Why to put a baby in a toxic stress of separation, when we can provide that care and when we can provide early initiation of breastfeeding. Similarly, in the KMC programs that we are starting off, we are looking at what Joy talked about, the WHO tool for up to age 3 screening, that how we can use that tool for screening KMC graduate babies for longer term follow-up and measuring those outputs. And it's also because at least 20% of the preterm babies do develop some kind of developmental disabilities. So when we are zooming into the real, children who would have problems, these are the babies who would have problems. And then the idea is that there would be, this implementation framework would be called Nurturing Care Framework, and it would be launched at World Health Assembly next year. So hopefully the good thinking would come together, and as Joy also said, there's a lot of need to work on tools and a lot of need to work on to identify metrics, which kind of cognitive development measures will be used, because there are different frameworks around that. And this is just an advocacy slide where we're talking about that there should be policies, there should be investment in this by governments, and the services should be there where the children need them. So I really like this quote, the quote, that if we change the beginning of the story, we change the whole story. So maybe this stands true for ECD. Thank you.